successful years. Every year since inception, we have very successfully, we have given many residents entered into the different programs throughout the America. And we have added numerous new ideas to accomplish for your goal and to get into the residencies. This academic year of 2020 will be begin on July 1st, and we will have 56 residents entering into different programs throughout the country. I'm not going to get more time. Those who are waiting, everybody welcome. And I'm going to give it to Dr. Barnali Hasan, who is the Young Physician Secretary of the BMANA New York chapter. And let's focus on that. Let's start all about COVID-19 webinar of BMANA New York chapter YPCAP. Thank you so much.
Thank you, Dr. Yusuf, our director in YPCAP program, Young Physician Career Advancement Program. Good evening, ladies and gentlemen, and my senior doctors and my junior doctors, everybody salam. Since last more than 8 years, we started the YPCAP program. Many of our program were very successful, like every year we have the workshop, and last workshop was number 8. And we try to prepare all our applicants for the interview and application process one-to-one for 4 to 5 months for every year for last more than 8 years. We have achieved our success we are almost there. Last year and the year before, we are getting more and more residents in the residency program. 50+ applicants are getting residency last 2 years. We had health fairs, or all the young physicians helped us to make it successful. I think today's program is one of the best program in our BMANA New York chapter, that our young physicians, they are going to be starting the residency soon, or some of them are the resident already, and some are preparing for the test, and they are going to present COVID-19 A to Z. I thank to all the participants, all my senior doctors, and who are helping me behind the screen. Dr. Mahbub chowdhury helped me a lot. Dr. Sajjad, Mr. Sajjad, he helped me for the tech, and Sheikh Jilur Rahman, he's the engineer and motivational speaker, he helped us. Other than that, New York chapter, our mentors, Dr. Mujibur Rahman Mujumdar, Dr. Shajol, Dr. Kaji Shajol, and Dr. Atal Osmani, and I cannot mention all the names here, but everybody helped to prepare all the participants' lectures. Let's start. Our first person who is going to tell us about the epidemiology and virology. He is Dr. Arif bin Saleh. He is the residency applicant for this year. He has a coaching center, and he helped a lot of young physicians to study the USMLE 1 and 2. And he is a very bright, brilliant student. He is going to start the epidemiology and virology. Thank you.
Thank you so much. I'm happy to be here and presenting my presentation. Actually, for last 6 months, our life has changed, and everywhere in our workplace or in our home, in social media, everywhere we see COVID-19, and COVID-19. So we arranged a webinar, and it's all about COVID-19. So I'm sharing my screen. One second. I cannot share the screen. One second.
We saw your screen,
but it's Dr. Kazi's screen. Because it says host disabled participant screen sharing. So right now, I'm trying to, yeah.
Mahbub, you have to let him share the screen, please.
It's host disabled participating?
In this preparation,
Can Mujib start? Can Mujib start something as a chief mentor, please? Mujib, Dr. Mujibur Rahman Mujumdar.
First, Dr. Qadri, Dr. Shajal need to exit from sharing screen. First, Dr. Shajal need to exit sharing screen, please.
Our stories tonight, we celebrate African American history.
It was all good yesterday.
Done. Done.
W. Bush's National Security Advisor and Secretary of State said to me,
Shajan.
those two ways to deal with people.
Would you please kindly allow Mahbub to become the host? In the meantime, I can tell some important things.
Request for sharing screen.
You can invite Mujib as a chief mentor, please, to speak.
No. Request for sharing screen, then I can do share. Shajan.
Arif, can you request the sharing screen?
Okay, please Please request for sharing screen, then we can approve.
Dr. Roman, would you please make a Mahbub as a host also? He can put
I
it
made
on.
it. A request for sharing screen, then I can let you share. Did you request?
Arif, why don't you request?
Yeah, I have been requesting several times.
Just enable it.
And it says host disabled participant screen sharing. Can anyone else try to share? Can anyone else try to share the screen so that it's actually working? But it has been disabled.
Only host can share.
Yes, only host can share. That's why I cannot share it.
ভাই আপনি ওই যে শেয়ারিং স্ক্রিনে যে আপনি জাস্ট বলেন যে ওয়ান পারসন অথবা মাল্টিপল পারসন শেয়ার অপশন চুজ করেন তাহলে ঠিক হবে।
Arif,
Yes.
The Dr. Shajal need to unshare, exit from his sharing because
Yes. Now I can share.
Now you can.
Now I can share.
Yeah, I did it.
Okay. Sorry everyone for the delay. So our presentation is all about COVID. So to discuss about the COVID, we have to go back. So if we look at last 20 years, according to WHO, viral disease continue to emerge and represent a serious threat to the public health. If you look back to last 20 years, first SARS-CoV in 2002 and 2003, H1N1 influenza in 2009, and Md respiratory syndrome virus in 2012. Then around November last year, a lower respiratory tract infection appeared in Wuhan, and it is the largest metropolitan city in China's Hubei province. At first, the disease was classified as pneumonia of unknown etiology, as the causative agent was unknown. WHO first on December 31st, WHO declared it as epidemic, and soon it became pandemic. On March 11, 2020, WHO declared it as pandemic. So, International Committee for Taxonomy of Viruses named the virus as Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2, on 11th February 2020. WHO Director General Dr. Ghebreyesus announced that the disease caused by the new virus is COVID-19. And in current situation, we can see it's everywhere, all around the world, Europe, America, Asia, India, Bangladesh, South America, everywhere the virus is. The first death on 11th January 2020 in China. According to Center for Infectious Disease Research and Policy, first reported death of COVID-19 in USA on February 2020. Till now, there are more than 8.5 million confirmed cases around the world, and it infected almost all countries. Around 500,000 deaths of COVID-19 till now. This picture was taken from Almast Hospital around mid-April. And the hardest hit around the world, it came to New York, especially New York City, and New York State lost almost 25,000 of its citizens on COVID virus. And in this situation, welcome to my presentation, and I'm discussing the virology. And I'm Dr. Arif bin Saleh. I'm a resident applicant this year, and I'm from New York, USA. So if we see the classification, it belongs to the subfamily Orthocoronaviridi of coronavirus family. And Orthocoronaviridi family has 4 genera: alpha coronavirus, beta coronavirus, delta coronavirus, and gamma coronavirus. SARS-CoV-2 belongs to beta coronavirus genus. If you look at the structure, we can see SARS-CoV-2 is positive strand RNA virus, and it has a crown-like appearance under electron microscope due to the presence of spike glycoprotein on its envelope. Those are the spike glycoprotein, and its actual picture of COVID-19. The thing is, spike protein, so far the most important glycoprotein. Okay, I will going to this discussion later. So in an animated picture, we can see there are several proteins. This is membrane protein, RNA. This is the actual RNA, and there is nucleocapsid protein on RNA. And this is the spike protein. It is critical for binding host cell receptor to facilitate the entry to host cell. And there is envelope protein on the envelope too. For more discussion, we can see this is the spike protein, and it actually attached to SCE2 receptor on host cell. That's why without these things, it cannot infect. And if we can block this receptor or the protein, we can actually make the vaccines. So for the genetics, from the genetic points of view, SARS-CoV-2 is closely related to the original SARS coronavirus. It is 96% identical at the whole genome level to other bad coronavirus sample. A complete genome sequence has 30,748 nucleotides in its RNA of a prototype of SARS-CoV-2. Random mutation happens during transcription. 7 strains so far has been identified, which can actually infect human. So a mutation, it is the main challenge because it mutates so rapidly that the surface proteins, especially the spike protein, it changes. So it's hard for the drug and vaccine developers to develop any effective drug or vaccine. So it is it throws actually the main challenge. Dr. Francis Balak, a PhD from University Hospital London Genetic Institute, said in a statement that a major challenge to defeating virus is that a vaccine or drug might no longer be effective if the virus has mutated or keep changing. he also added, if we focus on our effort to part of the virus that are less likely to mutate, we have a better chance of developing drugs that will be effective in the long run. And I am at the end of my presentation. Last, not the least, I want to show a picture, and it is the picture, and it was taken on 7th June. We can see, I said, we have lost almost 25,000 New York citizens for COVID. So from March 3rd to June 7, it happened. So we can see from this 100-day, our first target was to flatten the curve, but our physicians and healthcare workers did a tremendous job in New York. Then we not only flattened the curve, we already bent the curve, and we are in phase 2 of the opening. And if you compare to the rest of the USA, they are in a flattening position, and their death is also high. And the total death so far today is 122,000 deaths all over USA. And that's all my presentation. My other colleagues are going to present every other aspect of this virus. Thank you so much.
Thank you, Dr. Arif bin Saleh. You can, all of you can see all the stuff in my hand. I think you know what I'm going to talk about, to request to talk about. Dr. Khondokar Hassan Shoshi. He is the former assistant registrar at National Institute of Cardiovascular Disease and Hospital. He is preparing for USMLE for now. He's going to tell us about the transmission and how to prevent the COVID-19. Thank you.
Thank you, Dr. Barnali Hassan, for letting me perform today's webinar. It's a great opportunity for me to come over here to speak a few words. Today, I'm going to discuss about the COVID-19 disease transmission and prevention.
Dr. Arif, would you please take off your screen so Dr. Khandokar Hassan can start his screen?
Can you see my screens?
Not yet.
Hello.
Dr. Arif, would you please take off your screen?
Yes, I already stopped the sharing.
But your picture is still on the screen.
Just a second, let me try again. Is everything okay right now?
Yeah, your screen is sharing.
Yes, go ahead.
Start your video. Screen is nice. Start your video.
Okay,
Fine.
sorry for the interruptions.
No problem. Go ahead.
I'm Dr. Khondokar Hassan. I'm going to present today the transmission and prevention of COVID-19. The COVID-19 pandemic has proven to be more than just a threat to our health. It's become a disruption of our way of life, occurring over a wide geographic area and affecting everything from supply chains to the way we love, to what is considered the essential work. Let's talk about the mode of transmission. We all know the transmission is either by person to person or community spread, or it can be transmitted by the pets. The person-to-person transmission can be either by droplets, aerosolized transmission, surface transmission, or fecal oral. The virus most often is spread through the people who have symptoms, but it may be possible to pass it on without showing any sign. Some people who don't know they have been infected can give it to others. This is called the asymptomatic spread. You can also pass it on before you notice any sign of infection, called pre-symptomatic spread. Few people ask about what's the connection between pets and COVID. A few pets have tested positive for the new coronavirus. Not all these animals had sign of illness, but some have mild symptoms. The animals may have caught the virus from close contact with humans who are infected. How is transmitted? I already discussed. We can skip this. And It's very important to know about the COVID-19 in different surfaces. We all know that in sprayers, it can survive up to 3 hours. In copper, it can 4 hours. In plastic, it can be up to 2 or 3 days. In the cardboard, it can stay up to 24 hours. In steel, it can up to 2 to 3 days, and wood up to 4 days. So there's a lot of question that is how easy is it to get infected? Researchers say that on average, every person who has COVID-19 will pass it on to 2 and 2.5 times to others. One study says that the number is even higher, with one sick person infecting between 4.7 and 6.6 times to others. Can I get infected from delivery, food, package, and groceries? Yes. It's highly unlikely that you will catch the COVID from packages, groceries, or food. The important thing is to limit your contacts with other people. If you do your own shopping, try to keep at least 6 feet away from others in the store. That might not be possible all the time. So wear a cloth mask too. If you use a delivery service, have them leave groceries, food, and package outside your front door if you can. Many people infected with COVID-19 show mild symptoms, especially during the first stage of the disease. Thus, you can still catch the disease from an infected person who only has a mere cough and does not feel ill. It's a good news that about 80% of the people recover from this disease without needing special treatment. Right now, the reported cases of COVID-19 in USA is more than 2,317,400. And reported case in COVID-19 globally is more than 8 million. The preventive measures. Before preventive measures, I would like to share some misconception. The people always think that salt and vinegar prevent the infection. Eating garlic and drinking hot water prevents infection. Young people are not affected by the COVID-19. These all are false beliefs. So timely and evidence-based information is the best vaccine against rumors and misinformation. Now come to the point, protecting yourself and preventing the spread of the disease. Wash your hands with your alcohol-based sanitizer with soap and water for 20 seconds. Keep a distance of at least 6 feet between yourself and anyone coughs and sneezes. Try your best not to touch your eyes, your nose, and your mouth. Cover your mouth and your nose with a bent elbow or a tissue when coughing. Seek medical attention or self-quarantine if you have any difficulties. Follow the direction of your national and local authorities. Protective measures if you are visiting in infected areas. Stay home if you do not feel well, even if you feel mild symptoms such as headache, slight fever, and a runny nose. If you need to go out, for example, to buy food or supplies, wear a mask to minimize the risks of infective agents. If you have difficulty breathing or high fever, seek medical advice as soon as possible. Call your provider and inform them of any recent travel, especially to countries with reported cases. Is the photo just for the social awareness, safe distance, and older adults? We know the older adults are susceptible to infection, so we better not to get in contact with them. One thing, transport rules whenever with minimum distance. And we know that in social media awareness, our Bangladesh Medical Association of North America, New York chapter, they started campaigning from the beginning of the pandemic, and they award the social people and everyone else. And last of all, I want to salute all the COVID fighters, all the physicians and healthcare workers are on the front line of the battle in the novel coronavirus. Thank you from everyone for the sacrifice you make every day, and especially during this pandemic. Your dedication, commitment, and courage deserve our deepest gratitude and admiration. Your service is the patient, is saving countless lives and making thousands of difference. Thank you all. Here I conclude my speech. Thanks to all.
Thank you, Dr. Khondokar Hassan, for your nice presentation, and it is going to help us a lot. And now our next presentation is Dr. Jannatul Ferdush. She's preparing for her USMLE preparation. Currently, she's working with the hospital as a volunteer and in the medical assistant program. in different doctor's office. So Dr. Jannatul Ferdush is going to present us signs and symptoms. Thank you.
Good evening, everyone. My name is Jannatul Ferdush. Thank you so much, Dr. Barnali, Hassan, and Bangladesh Medical Association New York chapter for letting me the opportunity to be a part of this webinar. Today, I'm going to present my clinical manifestation of COVID-19. The incubation period for COVID-19 is around two weeks after the exposure of symptoms. The median age around 4 to 5 days. So who is the risk factor for COVID-19? As we all know that the advanced age, along with other comorbid illness, such as hypertension, diabetes mellitus, chronic kidney disease, and obesity, one of the important factors for the risk factor for COVID-19. So what's the clinical symptoms for COVID-19? As we all know that majority of people have COVID-19 experienced fever, cough, and fatigue. The fever is almost always present, but few of them are getting recovery without any fever, although they have COVID-19 positive test. But there are some atypical symptoms right now we are experiencing. There is something skin changes, as you can see in my pictures. They say it is COVID toes. And there is some abnormal, like conjunctival conditions also is the feature of the COVID-19. And some patients also experience body ache and diarrhea. What's the spectrum of disease? As we can see, there is a 4 categories like asymptomatic, mild to moderate, and few of the like percentage of severe, and few of them need like ICU admission or ventilations. But as my colleague mentioned, 80% of COVID patients, they have mild to moderate symptom and doesn't need to be medical intervention at all. So asymptomatic patient has, as I mentioned earlier, like upper airway type symptoms and some atypical symptoms like diarrhea and loss of taste and smell sensation, which can be recovered after recovery from the disease. So some maybe goes to mild cases on pneumonia, is viral type pneumonia. We can see on radiography is bilateral infiltrate. The severe pneumonia, we can see the patient has respiratory distress and the saturation of oxygen will be down 90. Those patients needed to be either hospitalized or need to proper management. So the severe pneumonia may lead to ARDS. On the other hand, we can see ARDS has bilateral opacities not explained by heart failure, and they have persistent inbred oxygenations. So that pathogenesis will be discussed by my next colleague on their pathogenesis section. There are some extrapulmonary manifestation on COVID patient we can experience. They have some cardiovascular complication. As we know, that patient will often complain. They have chest pain, which may lead to myocarditis or myocardial infarction. Myocardial infarction will be demand ischemia, and some have arrhythmia and some venous thromboembolism. And you can see there is a young patient where we can see has stroke, less than 50 years, without any underlying conditions. And there are some kidney issues, the AKI also, and some CNS manifestation. We can see cerebrovascular disease. And other inflammatory complication, we can see Guillain-Barré syndrome after the 5 to 10 days after initial symptoms of COVID-19. So other than adult, the COVID also impact on the children. So how the children and adolescents present their symptoms. So we can see the fever, which lasting more than 24 hours, and the patient also have severe abdominal pain, vomiting, and skin rash. As you can see, there is a redness and swelling in the lips and tongue in my pictures, and the conjunctival condition that experienced by the children, and that is like recently as complicated like is some autoimmune disease like Kawasaki-like disease and toxic shock-like syndromes. The CDC has case definition, as they say, this is multi-system inflammatory syndrome for the children who is affected for COVID. They have some guideline for these children, like the age will be less than 21 years of age, and there should be more than 2 organ involvement, and the alternative, no alternative possible diagnosis. And the patient must have contact with COVID infected patients, or they have RT-PCR positive test. So there is a, you can see the case definition for CDC or MISC. So how can you differentiate, like, is it MISC or Kawasaki disease, like syndrome? I mentioned there are few of those bullet points. Then you can see the age will be important, like MISC has the age will be more than 5 years and the adolescent. On the other hand, the KD has the infected child will be less than 5 years of age. The most presenting symptoms for Kawasaki MISC has severe abdominal pain. On the other hand, that KD has the GI symptoms will be less efficient. On the other hand, as we can see the lab finding, we can see the lymphopenia and ferritin and CRP level will be high in MISC patients. On the other hand, there is no lymphopenia overall at all in KD, and ferritin and CRP is not as much elevated. So as we can see, what's the complication for MISC is myocarditis and myocardial dysfunction. On the other hand, KD has 25 to 60% of baby that developed coronary aneurysm. So that is the differentiating point for MISC and Kawasaki disease. So that's all for my today's my presentation from my side. Thank you so much all for your attention. Thanks a lot.
Thank you, Dr. Jannatul Ferdush. It's a beautiful presentation. It will be very helpful for us. During the COVID situation, as a volunteer or as a physician, we used to get a lot of calls from different patients, like pregnant patient, and they just had a little delivered like 5 days, 8 days. So we have a lot of questions. We have heard a lot of questions. Now all the questions will be answered by Dr. Farjana Supty. She is preparing for USMLE, and she has participated in different television programs like NTV, Corona Coronio, to make awareness to our community in Bangladesh as well as in United States in America as well. Thank you. Dr. Farjana Supty.
Good evening, everyone. I welcome you all to my presentations. I'm Farjana Supty. I'm really happy and honored to work with all these respected physicians, and I would like to give a special thanks to Dr. Barnali Hassan who gave me this opportunity. Today, the part of my presentation is the pregnancy and coronavirus. So I have collected some information from various prestigious institutions like CDC, ECOG, American College of Institutions and Obstetricians, which are closely monitoring this pandemic and have made some valuable informations. So in this pandemic, many questions may be asked, like, do pregnant women have a higher chance of getting coronavirus? So although there are currently no data showing that COVID-19 affect pregnant women differently than others, but because of changes women go through during pregnancy, they might like to get some infections. Another question related like this, if a pregnant woman get coronavirus while she is pregnant, can she pass it to her baby? So according to ECOG, a recent case report detected SARS-CoV-2 in the breast milk, but majority data has not demonstrated presence of SARS-CoV-2 in the amniotic fluid and breast milk. But some of the babies born to mother with coronavirus have tested COVID positive. Lots of questions may come like this. What should women do if they are pregnant and get sick? So if women think she have been exposed to coronavirus, as a physician, I recommended to talk to your primary care physicians, your obstetrician, gynecologist over the phone before going to the hospital. She might have some symptoms like cough, fever, chills, repeated shaking with chills, muscle pain, headache, diarrhea, and she remembered about emergency sign. What is the emergency sign? Like shortness of breath, chest pain, leg swelling, sudden loss of consciousness. So she should get maternal care right away if she have any emergency sign. So what should do a pregnant woman to avoid coronavirus? To take some precautions that are being recommended for everyone as per CDC guideline. Washing hands with soap and water for at least 20 seconds, not to touch her face, wearing a face mask, to slow the spread of coronavirus infections, not to worry unnecessarily, stay at home, and avoid public transportation. Another important aspect is the vaccine during pregnancy. So although we know that there is no vaccine right now, the virus that causes COVID-19, So routine vaccine can play an important role to protect pregnant lady health. They can get routine vaccines like influenza, Tdap. So I'm going to my next slide. Pregnancy-related services could be delivered via telemedicine. So she can, her prenatal care, like virtual prenatal care visit at home. She can monitor her weight, blood pressure, fetal heart rate, blood sugar, consultation with her specialist like maternal fetal medicine, genetic counselors, her postpartum visual visits, lactation support, and maternal healthcare online communications with providers. So now I would like to talk about placenta. How does COVID-19 affect the placenta during pregnancy? This picture is showing that this is baby within the mother's womb and the connected placenta by umbilical cord and mother through the uterine wall. This placenta acts as a baby's life support, where the oxygen and gas exchange and nutrition are passing through mother bloodstream to the growing baby. And it acts as a baby gut, kidneys, liver, lungs for fetus during the pregnancy. So COVID-19 appeared to attack placenta during pregnancy. A small study has been conducted, Northwestern obstetrician physician, which is published on CNN, American Journal Clinical Pathology. The study shows that a small study, including 16 pregnant women, positive for COVID-19. They found the evidence of injury to the placenta. So what is the happen? The injury to the placenta, there is insufficient blood supply from mother bloodstream to the growing baby, and that might interfere with placenta's role delivering oxygen and nutrients from mother's bloodstream to the growing baby. So is it harm to the babies? Out of 16 in this research, 14 live-born infants in the study were born full-term, normal weight and Apgar score. The baby were born healthy, full-term, beautifully normal babies, although the blood was blocked and the placenta was smaller that should have. And only one born baby was a premature, and one patient suffered a miscarriage in second trimester. So we don't know whether the virus caused the miscarriage or it was unrelated. So during this pandemic, and the important aspect is the COVID-19 and breastfeeding. So within the breastfeeding, is it passed to the baby from mothers? Researchers are everyday learning whether COVID-19 can pass through the mother. But it is a good thing is that most information shows that it is safe to feed breast milk to their baby when they have COVID-19. Remember, breast milk is a very important source of nutrition from mother to the babies. It can prevent many infections like babies' ear infection, GI tract infections, respiratory tract infections. All of these informations, it can be said that if pregnant mother having COVID-19, she should not stop giving baby the breast milks. That was my last presentation. Thank you everyone for patience hearing.
Thank you, Dr. Farjana Supty, for your beautiful presentation. Now our next presentation is on pathophysiology of COVID-19, and this presentation, Dr. Mahbub Chowdhury as well as Dr. Talib Chowdhury will divide pathophysiology and the complications. Dr. Mahbub Chowdhury, congratulations. He is just accepted this year for the residency program as a PGY1. His program's name is St. Joseph University Medical Center in New Jersey. He had achieved many extracurriculum activity, and he has did many community awareness work through the flyer and his community work. And he also participated and helped us to prepare for the healthcare program, all the workshop program from our YPCAP program. Dr. Mahbub Chowdhury.
Thank you, Dr. Barnali Hassan, for your kind words. Assalamu alaikum and good evening, everyone. I'm going to talk about pathophysiology of COVID-19 virus and how does it affect the tissues and what happens after that. So before I go to patho-physiology, I know that previous speaker only talked about the mode of transmission, but I just want to touch upon on it. The most common mode of transmission is respiratory droplet, and it can be transmitted by coughing, sneezing, or even in close proximity if two people are talking and having conversation. But also it can be transmitted by fecal oral route. And so now, what are the target cells for coronavirus? So there are a lot of tissues, a lot of cells in different organs that possess one specific type of receptor that is called angiotensin converting enzyme type 2 receptor, and which is the target site for the coronavirus. So as you can see in this picture, there are a lot of cells which can attach those receptor with the virus and can cause symptoms. I'm going to talk about respiratory system, to be more specific, the lower respiratory tract, because that's the main target for the coronavirus. When we inhale the virus, it goes to our upper respiratory tract and then all the way down to the alveoli. And when it goes to the alveoli, as you can see, there's a picture of the alveoli. It's just a basic anatomical picture. We can see the alveoli is usually composed of type 1 pneumocytes, which is mainly responsible for gas exchange, that is taking in oxygen and giving out the carbon dioxide. And also there is type 2 pneumocytes, which mainly produce surfactant. The function of surfactant is to reduce the surface tension, which in turn keeps the alveoli open and preventing it from collapsing. So we can see the virus. When the virus comes in, we know the COVID is a positive sense single-stranded RNA virus, and it have several proteins on its surface. And there's one specific protein called S-spike protein, which then comes into the type 2 pneumocyte cell surface and recognize the angiotensin converting enzyme type 2 receptor. And then it attaches itself with this receptor. When it does, then both the receptor as well as the virus goes into the cell. And it uses the host cell's ribosome to produce different polyproteins. These are mainly the structural proteins of the virus, like capsids, like spike proteins, like cell membrane. It also uses the RNA-dependent RNA polymerase to produce RNA. So what it does, eventually it produces a new virus, and that's how the virus multiplies itself inside the target cell. So, and then after that, the virus comes out of the cell and it started to damage further more type 2 pneumocytes. And in the process, when the virus coming out from the pneumocytes, it also damages the cell. So it started to release some inflammatory mediators, which then attract the local immune cell, that is macrophage, alveolar macrophage. Alveolar macrophage then started to engulf the virus. And also it started to release some cytokines and chemokines. Cytokines, the more specific, are interleukin-1, 6, tumor necrotic factors. So what it does, the cytokines, the inflammatory mediators, then goes into the local circulation, that is capillary endothelium, and it causes the smooth muscle to relax. So there will be pores opening in the endothelium, and the fluid from the blood goes into the interstitium. And that's one way it is affecting our gas exchange. So we can see in this picture, there's type 2 pneumocytes damage. When the fluid comes into the interstitium, it not only affecting the gas exchange, but it also eventually goes into the alveoli. So, and then it washes out the surfactant. So as a result, there will be increased surface tension and alveolar collapse. Also, just to remember that when the fluid is also outside of the interstitium, it also compresses the alveoli, so alveoli cannot open itself properly. So that's one way it's causing damage to it. So as a result, all these things affecting the gas exchange. So there will be decreased oxygen level in the blood, which we know as a hypoxemia. And hypoxemia, then the body will try to increase work of breathing because alveoli are collapsing. So the lungs will try to breathe more to keep it open. So now we talked about the local immune cell. Now it's kind of the systemic immune cell. When all those chemokines are released by the macrophage, it then recognized by the neutrophils. And neutrophil comes into the system, comes into the scene. it's also then started to destroy the viruses and by releasing reactive oxygen species and proteases. But in the process, it not only destroying the virus, but it also started damaging the type 2 and type 1 cells. As a result, in the alveoli, there will be dead cells, there will be proteinaceous material, and there will be fluid. And this will turn into consolidation, which is a problem for the patient. And this consolidation will further decrease the gas exchange, and it also mechanically irritates the nerves, and it started to cause cough, which is a very common symptom and sign for the patients, COVID patients. Now, as we said, that there is a decreased oxygen level in the blood, which is sensed by the chemoreceptors, and it then stimulates the sympathetic nervous system, which then increase the heart rate, because heart is trying to increase the blood by increasing the oxygen to cover up the oxygen demand. And also it increases the respiratory rate to decrease the carbon dioxide level that presence in the blood and increase oxygen level. So that's the very common findings, the symptoms that we see in the COVID positive patients also. Now, if we talk about the circulation, so when the multiplication of virus is too high, so as normally there will be more inflammatory mediators, and then it will eventually move from local circulation to the systemic circulation that is all over the body, and started to produce its effect in all over the systems, which can be serious, which can produce a systemic inflammatory response syndrome, which also we know as a cytokine storm, and which is also very dangerous. So what happens when the inflammatory mediators are all over the circulation? It started to decrease blood volume by smooth muscle relaxation, so fluids are going into the interstitium. There will be decreased peripheral resistance. As a result, there will be hypotension. And because of hypotension, the organs will not be enoughly perfused, so there will be multi-organ failure, which can cause septic shock, and which is also a very dangerous complication. Now, all those inflammatory mediators that can usually transmit through the blood circulation into the central nervous system, and then it goes to the hypothalamus, which then releases prostaglandin, which started to increase the body temperature, as we know as a fever. It can also goes to renal system and as well as hepatic system. In renal system, because there is decreased perfusion, the blood urea nitrogen as well as creatine will be high. And in hepatic system, the liver enzymes will be high because of the damage by the virus itself. There will be increased bilirubin level and increased level of acute phase reactants like C-reactive protein, fibrinogen, ferritin, as well as interleukin-6. Thank you all for listening, and I would like to thank Bangladesh Medical Association of North American Europe chapter for giving me this opportunity. It's an honor and privilege for me to participate in this webinar. Thank you.
Thank you, Dr. Mahbub Chowdhury, for your beautiful and very explained your pathophysiology. And now our complications will be presented by Dr. Talib Khondokar. I would like to tell one thing over here, that Dr. Talib Khondokar is one of our very brilliant student, and he is accepted in UHS, Wilson Medical Center, Binghamton in New York. He also got in New York, in Binghamton. He also got several involved with many community awareness in COVID-19 program, health fair as well. I have to tell you something, that we are very sorry, and in this time we lost many of our doctors, many of our colleagues, and many of our family members, our patients on this COVID situation. We are very sorry. I should have said it in the beginning, that we want to dedicate our program to those people, those who has sacrificed their life, all the doctors and the doctors' family, because they bring the all the infection at the home. Our young physician, Dr. Khandokar Talib, he also lost his father. We are very sorry for that. Now our presentation will be done by Dr. Khandokar Talib, PGY1, Wilson Medical Center. Dr. Khandokar Talib, thank you.
Thank you, Dr. Barnali Hassan. Thank you, everyone. Good evening, and and it is my honor and privilege to present topics in front of you. My presentation is today about the pathogenesis and the complication of COVID-19. This is the continuation of my previous speaker, Mahbub. So I will discuss about the complication of COVID-19. Complications are mainly the COVID-19 related pneumonia and cardiac injury like cardiomyopathy, pericarditis, pericardial effusion, arrhythmia, sudden cardiac death, hypercoagulability, cytokine storm, acute liver injury, acute kidney injury, encephalopathy, and stroke. So I divided this into systemic way, and first I will start with the cardiac complications. So a relatively high percentage of patients admitted with COVID-19 will have underlying coronary artery disease. So mainly the cardiac problems are involved by the direct or indirect effect of the COVID-19 viruses. The direct myocardial injury due to the hemodynamic derangement or hypoxemia, inflammatory myocarditis, stress cardiomyopathy, microvascular dysfunction or thrombosis due to hypercoagulability, or systemic inflammation like cytokine storm, which may also destabilize the coronary artery plaques. COVID-19, like any other influenza, have been associated with like 6-fold increased risks of acute MI. Second is hematologic complication. It is very common. Hypercoagulability is very common in COVID-19 patients. So the pathogenesis, we all know that the Burkitt's triad. Burkitt's triad consists of 3 components, including the endothelial injury, stasis, and hypercoagulable states. So the endothelial injury is by direct invasion of the COVID virus, and other sources of endothelial injury include like intravascular catheters or mediators like cytokines, interleukin-6, or other acute phase reactants or other complement levels. Stasis mainly due to these patients are immobilized and hospitalized in critically ill patients, and hypercoagulable states because of the increased level of prothrombotic factor, including the elevated factor 8 or elevated fibrinogen level and other prothrombotic microparticles. The hypercoagulability increases the risk of venous thromboembolism, and some of the experts term as a new term, it is thromboinflammation or COVID-associated coagulopathy. They call this a haque. And this coagulopathy is distinct from the DIC, like disseminated intravascular coagulations. But they have some similarity in the laboratory finding, like in DIC, we will get marked increased D-dimer or D-dimer. You also in the COVID-19, we will get increased level of D-dimer. But in the DIC, it is more similar like the compensated DIC, not like the acute DIC. However, in DIC, PT and APTT is higher, but in COVID-19 coagulopathy, PT and APTT are typically normal. Another complication is cytokine release syndrome or cytokine storm. So cytokine release syndrome is an acute systemic inflammatory response syndrome characterized by fever with or without multiple organ dysfunction. And the pathophysiologist, cytokine release syndrome is a supraphysiologic response that activate T cells and or other immune effector cells. The systemic inflammatory reactions of CRS is associated with increased level of inflammatory cytokines and activation of T lymphocytes, macrophage, and endothelial cells. Clinical manifestation include fever, rash, arthralgia, and it can manifest up to the multi-organ failure to death. COVID-19 also involved the GI system, and main pathogenesis usually by the ACE2 receptor. It binds with the COVID-19 binds with the ACE2 receptor in the intestinal epithelium, and it causes direct viral attack as well as tissue and organ damage due to the immune response. And COVID-19 virus is evolving, and its effects of existing chronic GI disorder still remain uncertain. The renal complications include AKI, hematuria, proteinuria, and potentially higher risk of mortality. It is due to the hemodynamic changes and cytokine release, or maybe due to the direct cytotoxicity. There is a large cohort study in New York City was done in infected hypertensive patients, COVID-infected hypertensive patients. This find that the rates of severe COVID-19 were same among the patient taking ACE inhibitors or ARB compared with those using different antihypertensive drugs. The neurologic complications in critically ill patients are common, especially delirium or encephalopathy, which manifest with prominent agitation and confusion along with corticospinal tract signs. In addition, in MRI finding, there is some finding of ischemic stroke, and MRI also demonstrated the leptomeningeal enhancement. And the other complications include encephalitis, Guillain-Barré syndrome. So here is some take-home message. COVID virus uses the ACE2 receptor to facilitate the viral entry into the target cells. An ACE2 receptor is expressed in multiple tissues throughout the body, including type 2 pneumocytes, myocardial cells, cholangiocytes, enterocytes, and oral mucosal epithelium. COVID antigens are not detected in extrapulmonary tissue besides the hilar lymph node, and pathologic finding in other tissues were attributable to other underlying concurrent conditions. Some of the underlying conditions like hypertension or COPD are associated with upregulation of ACE2 receptor. Possible correlation of this condition with COVID-19 severity warrants further exploration. COVID-19 cardiomyopathy and acute cardiac death during the clinical resolution of pulmonary disease have been found, and reports have been showed coagulation abnormalities in some COVID-19 patients. Abnormal biomarkers of hepatic injury may not be the results of direct viral infections of hepatocytes. The gastrointestinal symptoms are due to direct viral injury with ACE2 receptor or immune response, and the neurological complication like delirium, encephalopathy, stroke, GBS also noted in some cases. This is all about my presentations. Thank you so much for hearing me. Thank you.
Thank you, Dr. Talib Khondokar, for your nice and detailed presentation. Our next presentation will be made by Dr. Rezwanul Haque. He has participated many different channels and programs to make awareness in the community for COVID-19. One of them was NTV, Coronai Coronio, Dr. Rezwanul Haque, and he's going to present us lab findings in COVID-19.
Thanks, Dr. Hassan. Good evening, ladies and gentlemen. At first, I'd like to thanks to our honorable moderator, honorable YPCAP director, honorable president of BMANA, honorable coordinator, and all the respected organizers and the members of Bangladesh Medical Association of North America, New York chapter, for giving me this opportunity to participate in this COVID-19 webinar. I'm really honored. Today, I'll discuss about COVID-19 lab findings. Let me share my screen first. Can you see my screen?
Yes.
All right.
Yes, go ahead.
Sorry for interruption. Lab findings for COVID-19. Here you go. Particular lab features have also been associated with URS outcome. These include, there is a bullet point, so neutrophilia, lymphopenia, leukopenia, thrombocytopenia, elevated erythrocyte sedimentation rate. And the elevated D-dimer, elevated prothrombin time. You know, the D-dimer is a very crucial. In the COVID-19 patient, there's a markedly elevated D-dimer. As we know, to exclude D-dimer, check D-dimer to exclude and blood clot. Also, the elevated inflammatory marker is, for example, elevated C-reactive protein, elevated ferritin, decreased albumin, elevated liver enzymes. For example, elevated aspartate aminotransferase, alanine aminotransferase, gamma glutamyl transferase, alkaline phosphatase, serum bilirubin, elevated lactate dehydrogenase, elevated creatinine, elevated blood urea nitrogen, elevated creatine phosphokinase, elevated lactate. There's also a few cardiac marker, elevated CKMB, elevated myoglobin, elevated troponin. The troponin is also very crucial. In A- stroke is a markedly elevated troponin. As we know, the COVID-19, there is a development of local thrombemboli. And in case of COVID-19 patient, if COVID patient, they have the few comorbidities, for example, the diabetic mellitus is mandatory to monitor the blood glucose level at regular interval. Let me go to my next slide. As an example, in on a study, progressive decline in the lymphocyte count and a rise in the D-dimer over time were observed in non-survivor compared with more stable level in survivors. The patient with severe disease have also been reported to have higher viral RNA level in respiratory specimen and those with milder disease, although this association was not observed in a different study that measured viral RNA in salivary specimen. Here we go. Lab test for COVID-19. The type of test, the nucleic acid amplification test for viral RNA, and then antibody detection. Nucleic acid amplification test by RNA, the specimen nasopharyngeal swab, oropharyngeal swab, sputum, bronchial lavage, fluid others. The measure is the current infection with SARS-CoV-2. There is a value and beneficial also. And the antibody detection, the measure is a past exposure to SARS-CoV-2. There's also other lab tests, the CBC differential. Usually we find the median WBC 4.7 with leukopenia in 30 to 45%, leukocytosis in less than 5%, lymphopenia in 33 to 85%, median platelet normal but slight decrease in 27 to 75%. That means clue to COVID-19, leukopenia and lymphopenia. Liver function test, aspartate aminotransfer, alanine aminotransfers increase in 4 to 22%. The CD80 protein test increase in 61 to 86%. Lactate dehydrogenase increase in 27 to 75%. There's also microbiology testing, the rapid flu or respiratory syncytial virus test, and the blood culture or sputum culture. Co-infection rate with virus and bacteria is unknown but is low in published studies to date. The presence of an alternative viral serology, for example, influenza, makes COVID-19 less likely, exception rhinovirus since this is a common co-pathogen. Bacterial co-infection might increase with severity of illness in a severely ill patient. Now there is a quick question. What are the most common lab findings in patients with COVID-19? Now the answer is the lymphopenia. The 83% is the most common lab finding in hospitalized patient with COVID-19. That's all for my presentation. Thank you.
Thank you, Dr. Rezwanul for your beautiful presentation. We learned a lot of important things and which is the most important to look for it. Now, Dr. Zobayer Ahmed, he was a medical officer in ICU in Holy Family Red Crescent Medical College. Now he's getting prepared for USMLE test and getting ready for residency applications. I want to thank all of our young physicians, and they really did, I think they are doing very great job. So Dr. Zobayer Ahmed is going to tell us about radiological findings. Thank you.
Thank you, Dr. Mohammed Hassan. I am Dr. Zobayer Ahmed, and good evening, dear audience. I am presenting here about COVID-19 imaging study. Thank you, Bangladesh Medical Association of North American New York chapter, to give me the chance to present here. So first of all, I'm starting about the chest X-ray findings in COVID-19 patients. The chest radiograph for COVID-19 patients may be normal in the earlier stage of the diseases. Initial findings on chest X-ray are predictive of hospital admissions and intubations of young and middle-aged adults presenting of the ER with COVID-19. They report clinicians with New York City. Dr. Daniel Tushi of Icahn Medical School of Medicine and Mount Sinai Hospital, he describes the chest X-ray like this simple and widely available imaging test can actually tell a lot about a patient's clinical status and whether recurrent hospitalizations and progress to needing mechanical ventilation or intubation in the ICU. The next slide, this shows that the Dr. Tushi's teams divide the patient's chest X into 6 zones. And after that, they divided, adjusting the demographic and comorbid conditions. The chest X-ray severity score of 2 or greater was an independent predictor of hospital admissions, and a score of 3 or greater has an independent predictor of intubation or mechanical ventilation. This is a chest X-ray, and in this X-ray, we can see this is the consolidations, and there's consolidations, so bilateral consolidations in COVID-19 patients. Next one is the ground glass opacity in COVID-19 patients. And next one is the lung ultrasound findings on COVID-19. Although lung ultrasound is not a good imaging study for any kind of chest findings, but it is used in some case of pediatrics and surgery cases. So lung ultrasound findings are consistent radiological findings in children in COVID-19. Researchers in Italy report. They find that subpleural consolidations in 2 children and confluent B lines in 5 children. This is a picture of lung ultrasounds. So pleural thickening, in this picture you can see pleural thickening. This is the patchy B lines, and this is the subpleural consolidation. The next one is the most famous CT scan findings of COVID-19. According to the Johns Hopkins Center of Health Security, the chest radiograph for COVID-19 patients may be normal in early or mild disease. In a retrospective study of 64 patients in Hong Kong with documented COVID-19, 20 patients did not have any abnormalities in the chest radiographs at any point during the illness. The next one is the common abnormal radiography findings of chest imaging of COVID-19 patients. It includes the consolidations and ground glass opacity with bilateral peripheral and lower lung zone distributions. Lung involvement increase over the course of illness and peak in severity in 10 to 12 days. The most common findings of COVID-19 chest CT scan is the multiple bilateral peripheral ground glass pattern. Is the most common finding. Sometimes crazy pattern and thickened interlobular and interlobular lines is also common. These are the types of chest radiography findings of COVID-19. The first one is the ground glass opacity pattern is 88%. The next one is bilateral involvement is 88%, posterior distribution is 80%, multilobular involvement is 79%, peripheral distribution is 76%, and consolidation is 32%. Although CT scan may be more sensitive than chest radiograph, the American College of Radiology recommends not using chest CT for screening or diagnosis of COVID-19 and recommends reserving in patients who are critically ill and where there is diagnostic uncertainty. In a study of 1,014 patients in Wuhan in China who underwent both RT-PCR testing and chest CT for evaluation of COVID-19, a positive chest CT for COVID-19 has a sensitivity of 97% using the PCR test as a reference. However, the specificity is only 25%. This is a CT scan, and in this CT scan, we can see there's a ground glass opacity bilaterally in the lungs. And the next one is the CT scan of chest consolidations in COVID-19 pneumonia patients. Excuse me. Next one is CT scan findings on COVID-19. So if CT scan is performed, the Radiological Society of North America has categorized features are typical or atypical for COVID-19. The specific chest findings may some be characterized of COVID-19 patients. No findings can completely rule out or in the possibility of COVID-19. As the chest radiograph, the CT chest may be normal soon after the onset of symptoms, with abnormalities more likely to develop over the course of illness. The next one is the MRI significance on the COVID-19. Although MRI is not a good test for imaging of the chest, but MRI recognized, but sometimes it is used to diagnose of chest problems. So magnetic resonance imaging is a method of visualizing the lungs and has several disadvantages. Like due to the high airiness of the lung tissue, fewer water molecules to form a signal and lowers the signal to noise ratios, which results in poor quality images. In addition, susceptibility effects which lead to more pronounced signal attenuations. MRI has inferior anatomical resolutions and is compromised by inevitable artifact due to motions. However, the possibility of the MRI imaging in relation to visualization of the lungs are consistently expanding due to both the technical improvement of the MRI equipments and the emergence of more complex pulse sequences and techniques. It has also been shown that MRI has a high magnetic field and has a higher signal to noise ratio than thoracic imaging. So thank you everyone, and that's all for today, and thank you.
Thank you. Now our presenter is Dr. Mithun Bhowmik. He is also preparing for the USMLE test, and he is going to tell us about how we can diagnose COVID-19. Thank you, Dr. Mithun Bhowmik.
Good evening, everyone. It's my honor to be here
to talk about ongoing pandemic for which the whole world is in crisis. And I would like to thank Bangladesh Medical Association of North America, New York chapter, and also today's moderator, Dr. Barnali Hasan, for giving me the favor to be part of today's webinar. From my side, I will talk about how to diagnose COVID-19. So to diagnose any test, any disease, we need to do test. Ideally, we should test everyone to have a real-time information that will guide our clinical management and infection prevention strategy. But the reality is that we can't test everybody because we have a limitation in reagent and swab and also staff or personnel who will process the sample. That's why Center for Disease Control has fixed some criteria for testing, and it also recommended that any patient with severe respiratory illness, regardless of travel history or exposure to individual with confirmed infection, should be suspected for COVID-19. And Center for Disease Control also categorized patient in two groups according to priority. In the first priority, it includes hospitalized patient with symptoms and healthcare facility workers, workers in congregate living setting, and first responders with symptoms. Also includes residents in long-term care facilities or other caregiver living settings like prisons or shelters. Second priority includes patients with symptoms of possible COVID infection symptoms like fever, cough, shortness of breath, chills, muscle pain, new loss of taste or smell, vomiting or diarrhea, and or sore throat. And also includes persons without symptoms who are prioritized by health department or clinicians. So as of now, there are some tests available to diagnose COVID-19. In my next few slides, I will go through all of them. First of all, there is rapid diagnostic test based on antigen detection. It usually indicates active or early infection, and it has sensitivity of 34 to 80%, but it gives some false positive results. That's why WHO doesn't recommend it to use as a diagnostic test for COVID-19, but we can use it as a triage test. Then comes another rapid diagnostic test based on antibody detection. Antibody like IgM and IgG. WHO also doesn't recommend it to use as a diagnostic test for COVID-19 because antibody usually becomes detectable after 1 to 3 weeks of symptom onset. But we can use it for clinical assessment of COVID-19 patient. We usually tested 9 to 14 days after symptom onset. But in addition, we need to do a viral detection test. Here is a slide where you can see when antibody is usually appear in the blood. First of all, there is IgM. It usually appears 7 days after the symptom onset and usually indicates active infection. And after that, the second antibody, IgG, usually appears after 14 days of symptom onset, and it usually indicates recovery or past infection. And there comes the gold standard test for diagnosis of COVID-19, and that is called real-time RT-PCR test. So how does it work? By real-time RT-PCR test, we usually directly detect the SARS-CoV-2 RNA virus, and it can detect any small amount of viral RNA, and it has high sensitivity and specificity, maybe more than 90%, and it takes usually 6 to 8 hours to give result, and it has less contamination or error. That's why it is considered the gold standard test for diagnosis of COVID-19. So to do the test, we need to collect specimen. Usually upper respiratory samples are preferred for doing the RT-PCR test. And nasopharyngeal, we can collect nasopharyngeal swab, oropharyngeal specimen, nasal swab specimen from both anterior nares, and nasal and naropharyngeal wash. But nasopharyngeal specimens are preferred as they have higher sensitivity than oropharyngeal specimen. We can also collect lower respiratory tract specimen like sputum, bronchoalveolar lavage, tracheal aspirate, pleural fluid, lung biopsy. But these are reserved for hospitalized patients who have an initial negative test with upper respiratory tract specimen, but for whom suspicion for COVID-19 infection remains high. And it is to be noted that lower respiratory tract specimen have higher sensitivity than upper respiratory tract specimen. Here is another slide where you can see how to do the real-time RT-PCR test. First of all, we collect the sample, usually from nasopharyngeal swab. Then we usually extract the viral RNA. Then we introduce an enzyme called reverse transcriptase, and that usually produces the DNA.
make DNA from RNA, then we amplify the DNA. And if the number of DNA crosses the threshold value, then it comes positive test, and if it doesn't, it comes negative test. We also do some supportive tests like chest CT, where we can find ground glass opacities or peripheral distribution of opacities, and also we do respiratory viral panel to exclude other viral infection like respiratory syncytial virus or influenza virus. Here are some points I want to restate regarding diagnosis of COVID-19, that sample for RT-PCR should be collected between first 7 days, and it is best when patient is symptomatic and nose is better than throat. And in those with lower respiratory tract infection, needs lower respiratory tract sample ideally, and for doing all these things, we need a big team effort and lots of collaboration. And that is all I have for the diagnosis of COVID-19. Thank you all.
What happened?
Papa, apni mute.
Sorry. Now the next presentation is the most important, and we are all wondering and we are all looking for it, how we can treat our patients. Like we can get the temperature, we can have the pulse oximetry to check it, but how we can treat it? Do we have still any specific treatment for this disease? Dr. Mohammed Hussein Mintu, he is one of our proud resident. He's finishing up his PGY1 in Brookdale Hospital and starting in PGY2 St. Mary General Hospital in New Jersey. He has achieved many academic activities. At the same time, he was participated many community work, health fair, community award, and here is coming Dr. Mohammed Hussein Mintu. Thank you.
Thank you, Dr. Barnali Hassan, for introducing me and giving me the opportunity to present part of the COVID-19 A to Z. And I especially wanted to thank YPCAP Director Dr. Fazlul Yusuf, mentor Dr. Mujibur Rahman Mujumdar, and the whole New York BMA New York chapter, who supported tremendously to this program to happen. Without their all support, it wouldn't be happening. So let me share my screen. Can you guys see my screen?
Yes.
Okay. So I'm Dr. Hussein. I'm going to present today COVID-19 treatment. Treatment approach. How do we treat the COVID? Initially, patient comes with some symptom, especially cough, shortness of breath, and fever. So we're going to talk about it. Then there are some recommendation about the few common medication that may have some beneficial effect on treatment. Those are not the specific treatment, but they help. It's like the side treatment. And also COVID-19 is specific treatment. And the fifth one is the complication of the COVID-19 that we treat. And lastly, the ECMO and the proning is the special kind of treatment for ARDS. This is a complication. So I'll talk all about it. Symptomatic treatment. You know, most of the patient, they feel fatigue, they come with shortness of breath. We check the pulse oximetry, found the patient is hypoxic. So the treatment for this, I have a slide, I'm gonna show it later, then the fever and the cough. For shortness of breath, if we think the patient is going to have hypoxia, the O2 saturation is less than 92 or respiratory failure, O2 sat is less than 88% or PO2 less than 55%, we can treat with any of those following. What are those options? Nasal cannula, non-rebreather, non-invasive positive pressure ventilation, venti-mask, high-flow nasal cannula, and intubation. The more simplest form is the nasal cannula, and the most severe kind of treatment that we need, the intubation. It depends on the patient mental status, patient physical condition, and the patient needing for the oxygen. The more oxygen needed, we go with the intubation. So fever. there is most of the time, the COVID has to have a fever. How do we treat it? Acetaminophen and NSAID. There was a controversy. Can we use NSAID? There was a controversy that NSAID has an adverse effect, but the CDC and all other recommendations says it's okay to use NSAID, but we need to use lowest possible dose. So the treatment for the fever either is fine, but we would recommend acetaminophen. And some special recommendation, as I mentioned earlier, and the guideline. What are those? Empiric treatment with the bacterial pneumonia in selected patient who has COVID. Do we do that? Answer is no, we don't empirically treat. If we suspect there is a co-infection with the COVID-19, then we treat with the antibiotic. Prevention and evaluation of the venous thromboembolism. You know, COVID can cause hypercoagulable state, then we do treat with the DVT prophylactic dose of anticoagulation. Uncertainty about the NSAID use, I told it's okay to use. Avoiding nebulized medication. This is a part of treatment. Why? This aerosolized nebulization can spread to non-COVID patient who is admitted into a hospital. So we recommend using meter dose inhaler. ACE inhibitor ARV. There was a controversy that ACE and ARVs has an adverse effect on treating COVID. The COVID may get worse, but it is not true. It's okay to use ACE inhibitor. Statin. This is a newer entity for the development of the COVID treatment. The COVID, you know, has a fascination for the fat cell. They like those fat cells. If you use statin, it might be beneficial. But all of them I'm talking about, we have limited data, limited research. We need more clinical data and research to comment on those as a standard care of treatment. And I'll talk about the immunomodulatory agent. So here is the first one I mentioned earlier. Empiric treatment for bacterial pneumonia in selected patient. We do not recommend treating for all COVID patients with antibiotic. But if the COVID is uncertain, we are not sure it is COVID or bacterial, then it's okay to treat with empiric antibiotic. We usually treat with azithromycin. So I have a slide later on, I'm going to talk about it. Prevention and evaluation for venous thromboembolism. So how do we treat to prevent that clot? We use prophylactic dose of the DVT. It's enoxaparin, that's the most common one. If it is there is a kidney failure, we don't use the enoxaparin, instead we use the heparin. The next slide is about the uncertainty about the use of the NSAID. Concern was that NSAID has an adverse effect, but actually the data that we have, it's okay to use as an antibiotic. Avoiding nebulized medication. Inhaled nebulization may spread to non-COVID patients, so we recommend use meter dose inhaler. ACE and ARV. We spoke earlier that if someone is already using ACE and ARV, we should continue treatment with those agents. There is no harm with using it, but some data we have seen recently that there might be a protective effect based on their mechanism that COVID goes to our body through the ACE receptor. So those, again, I have to say, study on the way. We need more clinical data and clinical evidence to say, yes, it is there is a beneficial effect. Statin is another newer entity. It just came out like 1 or 2 months. The researcher is working and there is a data coming because the fat cell has a the COVID has a fascination for the fat cell. So statin use might have a beneficial effect. And there is some inflammatory pathway blockage by the statin, that MDY88. So we might get in the future that statin might be a standard care of treatment for COVID, but it is not clinically and proven yet. Immunomodulatory agent like prednisolone and all other immunosuppressive agent. So the recommendation is we don't use immunomodulatory agent because they might give a chance to other viruses to infect us. Now, so those are kind of like supportive. Now, COVID specific treatment. As you know, in the era of the COVID, from February till today, we tried so many different kind of combinations, so many different kind of medication. Nothing we have came across that this is the best medication, this decreases the mortality. This clears the virus quickly. This fasten the recovery quickly. But there are two most popular one, I have to say. It's remdesivir and the convalescent plasma. But there is a pros and cons on both of them. So I have listed the standard care of therapy for COVID-19. The specific therapies: remdesivir, convalescent plasma, glucocorticoid, interleukin-6 patho-inhibitor, tocilizumab, favipiravir, interferon beta, interleukin-1 inhibitor, anakinra, azithromycin hydroxychloroquine, lopinavir ritonavir combination, some hyperimmunoglobulin, and monoclonal antibody. We are not actually, CDC and WHO didn't recommend all of them. These are the available treatment option, and it depended actually on physician preference. In some hospital, they tried lopinavir ritonavir in the beginning, then they stopped it. And other hospital, they started on glucocorticoid, they stopped it. So we tried different combinations. So I have to say it was depending on physician preference and case-to-case basis. So here is the most popular one. It is the standard of care now. The treatment for COVID is remdesivir. You know, it is a nucleotide analog that we recommend for the hospitalized patient in severe COVID-19 patient. Severe COVID-19 is, as one of our presenter was presenting, the patient has to have respiratory failure, patient has to meet some of the criteria, patient has to be in the shock, then they approve for those. So remdesivir is a standard care of treatment for severe COVID-19. And remdesivir has also, there's a lot of criteria. Oxygen saturation has to be low, then patient has to be on ventilation. If some patient is on ECMO, we can use those remdesivir. The two main complications that come across with the remdesivir is the liver function abnormality and the kidney function. We have to look for it if we use the remdesivir. So if the liver function is more than 5 times, liver LFTs are 5 times higher than the normal, we should not use the remdesivir. If GFR is less than 30, we should not be using it. So these are a little information about the remdesivir. And also one more important thing, you remember I was telling that earlier in the COVID era, we tried different combinations. So that time we have seen that remdesivir, hydrochloroquine, chloroquine we used, we should not use both of the combination, remdesivir and hydroxychloroquine and chloroquine together. There is a potential complication. So now, is remdesivir decreasing the reduces the mortality? We don't have enough data. Is remdesivir reduces the time of recovery? Yes. So we need more data. We might get a good study that might show mortality benefit that it will be standard of care. Convalescent plasma. So in the COVID era, we started using convalescent plasma in different hospitals with different physician preferences. But convalescent plasma also had some benefit and also adverse outcome as well. So the FDA has approved during that period accepting investigation new drug as a treatment for convalescent plasma. Still, it's okay to treat the COVID with the convalescent plasma, but the transfusion reaction and some other reaction was merging with it. So convalescent plasma was another choice of treatment. Glucocorticoid. So initially, when the COVID started, a lot of hospital and physician preferred glucocorticoid. It was kind of like standard care of treatment at that time. But nowadays recommendation, we should not be using glucocorticoids as a treatment for COVID. Why? The clinic, they saw there is no significant benefit. But in the UK, they had dexamethasone as an approved treatment for hospitalized patient, but not in USA. Then another group of the treatment that is very important, interleukin-6 pathway inhibitor, tocilizumab. That was one of the popular medication. The data showed that this decreases the inflammatory marker, this fastens the recovery of the patient. And there was, when I was preparing for this slide, some studies showed that there is some mortality benefit. So still, it's physician preference, it depends on the hospital, and it depends on case-by-case basis how we're going to use. In this same group of the medication, we have sirolimus and cetuximab. So those might be the popular in future. Again, all the work and a study is on the way. Once it comes out, we can recommend more. Hydroxychloroquine and chloroquine or chloroquine, there was another treatment option for us that those were some better option for treating COVID in the beginning. But nowadays, the study showed it is not beneficial for COVID treatment, so we stopped using it. We should not recommend treating hydroxychloroquine or chloroquine for COVID. There is other medication was emerging in the COVID time. There are some trial medication. One of them is favipiravir. It's a RNA polymerase inhibitor that is available in Asian countries. We don't use it here. It shows it fastens the recovery of the patient. So again, we don't have enough data, and it is not recommended in USA as of yet. Interferon beta, this is another treatment option. It actually showed that earlier in the MERS COVID, it worked, but nowadays the data showed that there is some effectiveness against the SARS-2 COVID virus RNA transcription polymerase. So they are blocking it, but we need more data to comment on it. Studies on the way. Other immunomodulatory agent like interleukin-1 inhibitor, anakinra kinase inhibitor, and complement inhibitor, they might be coming in future. You know, all this COVID does one thing. They make a cytokine inflammatory storm in the body. If we can block all those pathways, it might be helping with our treatment.
I can hear you.
Sorry. Okay. Hello? Now?
Yes, I can hear you now.
Okay. Sorry for the interruption. The next treatment option is azithromycin and hydroxychloroquine combination. Initially, we treated, actually, I was a part of it. I was in ICU rotation. We treated all the patients with the azithromycin hydroxychloroquine, but a study showed it is not associated with clinical benefit. So we don't suggest that nowadays to treat with hydroxychloroquine and azithromycin. There was another combination, lopinavir, ritonavir. You know, initially we tried so many different kind of medication, tried to see new disease, which medication works. So this was tried earlier in the COVID time, but nowadays we don't use. We need more data to see the effectiveness, but this was one of the treatment option. The last two treatment I have here, the picture, the prone positioning, like upside down, patients sit on the belly, and the ECMO, those are actually the treatment for the complication of the COVID, like when the lung completely damaged, as earlier some of our presenter was mentioning, ARDS and severe respiratory failure. When the oxygenation we cannot get in any means, even with the intubation, then we prone the patient, and also the last option that we try to help with the oxygenation, that's the ECMO machine. It gives the oxygenation with the artificial machine. So that's a short presentation. Actually, I could talk a lot, but I tried to summarize everything, give you the message. These are the treatment options. Thank you again, Dr. Barnali Hasan, for arranging such a nice program. You always there for physician. You are one of the most popular physician of all young. And Dr. Fazuli Yusuf, thank you for preparing us and helping us. And Dr. Mujibur Rahman Mujumdar was mentor of this program. And whole New York chapter, how they cares about the young physician. We are really happy to be a part of it. Thank you again.
Thank you, Dr. Mohammed Hussein Mintu, for your nice word to our New York chapters and everybody. Thank you very much. And can I see the crowd, everybody? Can you please turn it off, Dr. Hussein, your lab?
Oh.
Yes, can you please turn it off so we can see everybody? Okay. So there is lockdown. We are getting used to with the many words like lockdown. We're using all these sanitizers and the pulse oximetries. We are all using all this stuff. This we are continuously using. I just want to say one thing. Don't leave this in your car. because it can cause the fire hazard. And we will keep continuing to checking our pulse. If we have a fever, we can check it right away before getting all the situations. How long we can go for it? How long we can stay home? How can we do quarantine for everybody? We have the whole world is there looking for us. The kids are home. We are home. So we want to go ahead. Scientists around the world are working on potential treatment and vaccines for the new COVID-19. Several companies are working so hard. How we can get out of the house? That's only issue now. Dr. Fauci also telling us when we can get our vaccines. So guess what? Now we are going to talk about the vaccine, and then these vaccines are all over the news now. So Dr. Nibras Ahmed Chowdhury, he's from United Kingdom. He's over there now, and he's going to present us vaccines for COVID-19. Thank you, Dr. Nibras Ahmed Chowdhury.
Thank you.
I think it's very late night for you now. Thank you.
Yeah, it's almost 4 in the morning. So thank you for giving me the opportunity to present here. So my name is Md Rezwanul Chowdhury. I'll present about the development of COVID-19 vaccines. So normally the vaccine forces the immune system to make antibodies against the specific disease, usually by a dead or weakened form of the germs. So when the vaccine gives the immunity, the person don't get sick, or if the person gets sick, the severity of the disease will not be as much as it normally does. So as this virus is really new, it surfaced in the late 2019, but the scientists got some help from the research on some other similar coronaviruses like severe acute respiratory syndrome and Middle East respiratory syndrome. So some of those vaccines now in trials use messenger RNA. So the messenger RNA, what it does is that it carries the instructions for making the spike protein the virus uses to enter the human cells. So when the mRNA virus introduced in the cell, the immune cells of the body make that protein. So it makes the body to think that they are already infected. So it somehow gives the immunity against the virus. So this virus is still under development. Normally, its vaccine is under development. Mostly the vaccine development takes around a decade, but because of the urgency of the pandemic, the scientists are trying to compress it down to around 12 to 18 months. And this timeline has begun from the January of 2020. So now I'll talk about the stages of vaccine development. And there is like 6 stages. The first stage is the preclinical phase, where the collection of data to support feasibility, safety, evaluate toxicity, pharmacobiological effects, and this one is done on non-human specimen. And the phase 1 of clinical phase, where there is a small number of healthy people, it's taken and the study is done. It's around like 20 to 100 people, which evaluates the safety and immune response at different doses. And it normally takes around 1 to 2 years, but for the COVID-19 trials, the scientists are expected to do it within 3 months. And in the phase 2 of clinical phase, which is done with the study is done with 100 to 300 people, which further evaluates the safety, assess the efficacy, and informs optimal dose and vaccine schedules. And this phase is done normally within 2 to 3 years, but for the COVID-19, it's expected to be completed within 8 months. And the third phase, which is done within a broad base, like around 300 to 3,000 people, and which takes around 2 to 4 years, but the scientists are trying to combine with the phase 2. And then the regulatory review, where the government agencies reviews the trial data and licensing application information before approval. It takes normally 1 to 2 years, but it's expected to be done within a few months. And in these stages, while the government is reviewing the data, the production of the vaccines can be started. And then the clinical phase, where the post-approval study is done. And now, since as of June 2017, 2020, there is around 165 vaccines are development all around the world. And those vaccines falls into 9 different product categories or platforms. And out of those 165 vaccines, 11 vaccines are now in clinical trials. Now there's a table of COVID-19 vaccines that are under clinical trials all around the world. In the second column, you can see the developer. It's a different companies of around the world. The first one, the Moderna and NIAID. The third one, Inovio Pharmaceuticals. And the last one, Novavax, are from United States. And in the right column, you can see that most of the vaccines are already only in the phase 1 or 2 of development. But the fourth one, the vaccines which are developed by the University of Oxford and AstraZeneca, they are already in the phase 2B and 3 of development. So there's a geographical picture of the countries that are now developing the vaccines all around the world. So mostly they are from United States, China, United Kingdom, Australia, and some other countries. So the normally vaccine development takes a long time. The Ebola virus vaccine was discovered 43 years ago, but the US Food and Drug Administration has approved its first vaccine recently. So, because of the looming crisis of COVID-19, everyone is hoping that it will be different this time and the vaccine will be developed far more faster. So now I'll talk about a little bit about a herd immunity. The herd immunity means that the percentage of people which are immune to give the immunity to other population. So it normally depends on the basic reproductive number, which is R0. And so the first, when the virus came in the Wuhan, China, there was an initial cohort study that was done on 25 cases in there, and R0 was estimated around 2.2. But later on, the R0 went higher and it's 5.7. So because of the variation of the R0, the herd immunity percentage cannot be estimated correctly. But if we assume R0 is 3 for this virus, the herd immunity can be 67%. That means that the 67% of the population should be infected or vaccinated for the whole population to be immune. But the recent survey of 11,000 households in England suggested that the 1 in 400 is currently infected with the virus, which is only around like 0.27% of the entire population of the England. Even in France, the study led by the Pasteur Institute shows that only 4.4% of the France's population has been infected. Even the most infected area of the France has infection rate of only 9 to 10%. So this means that we are still really far from getting the herd immunity. And so that's is all about my presentation. Thank you very much.
Thank you for your wonderful presentation, Doctor. Now our next presenter is Dr. Mohammed Islam Pshychiatric. He's going to tell us about psychiatric manifestation. He worked in the Interfaith Medical Center as extern, and also he's an assistant professor of medical assistant and nursing program in CUNY. He has a lot of experience in this field because he's trying to get a psychiatric residency. This applications is going to tell us this COVID situation, where we are going to be in future and where we are standing now. Dr. Mohammed Islam Pshychiatric. Thank you.
Thank you. Thank you, Dr. Barnali Hassan, our moderator, and thank you all the executive members in Bangladesh Medical Association New York chapter. Thank you. And today I will I'll share my screen. Did you see my screen?
Yes, we can see.
Yes, we do.
Yeah, sorry. Yeah, today I will discuss and I will present my experience regarding psychiatric manifestation of the COVID-19. As I mentioned, I am Dr. Mohammed Islam, resident applicant in psychiatry, extern in Kings County Hospital and Interfaith Medical Center. Thank you, Dr. Barnali Appa, for your hard working. Now I'll tell you that exactly a limited number of studies describe the prevalence of the sequelae associated with the mental sequelae coronavirus 2019 among the different cluster of the people. We divided 4 groups of the people. Like first defense is a healthcare worker. The healthcare worker, it is a cross-sectional study and self-reported instrument during at the peak of endemic time. This like total physician and nurses more than 1,200 in China, and second line health worker more than 1,300 in Italy. They are suffering with anxiety 12 to 20%, depression 15 to 25%, insomnia 8%, and traumatic stress disorder, which is more common 35 to 49%. In addition, they have intense fearness, guilty feeling for family, suicidal ideation, and suicidal behavior. What are the most factors? What are the risk factors? The risk factor is or increased contact with the affected person, limited PPE, protective personal protective equipment, social stigma, and unknown infection and uncertainty of the disease. This is the most the cause. The second group of or cluster of the people who are actively infected with COVID-19, approximately 20 to 40% patients manifested with neuropsychiatric symptom consistent with delirium, and they are suffering. What is the cause? The cause is, the main thing is biological cause, direct invasion within virus within the central nervous system, and inflammatory changes as other person they mentioned that interleukin 1, interleukin 6, and increase the inflammatory change that cause a delirium. And then the rest of the people, insomnia 42%, impaired attention and concentration 38%, anxiety 36%, memory impairment 34%, depressed mood 33%, and confusion 28%, altered consciousness 21%. And then the third group of the patient who are present with the pre-existing psychiatric illness who had, and then they are suffering with anxiety, depression, bipolar disorder, but approximately 20 to 25% person think that they are coping poorly and then deteriorating their condition. So mental health problem, which I mentioned before, like anxiety, depression, insomnia is most common, but which are attributed. Why? Because to fear the infection, restriction of transportation in this pandemic, and isolation at home. The majority of the people, they are worsening their illness in the psyche. They have inability to receive treatment. It is the most 39%, and then running out of medication 38%. So the person who are schizophrenic, like chronic mental illness, who are mainly homeless, and also associated people who are suffering with schizophrenia, their cognitive difficulties and marginalized social status may impair their ability to follow the public health precaution like wearing masks and then wear gloves and social distance. It's difficult for them. It is new things for them. And then the fourth group is general population. General population also suffering with anxiety, depression, and PTSD. Why PTSD? Because they are lost their loving family members, and they are also still suffering with some critical situation. And then they are more distressed, especially who are the 50 years old, like who are divorced, who are widowed and employed as a healthcare worker. They are most. And what they are suffering? They are suffering with nervousness, helplessness, and depression. And they also suffering with intuition symptoms like nightmares, avoidance, and negative alteration in mood and cognition. And then chronic disease, who are the more than 70 years, like immunocompromised patient with diabetes, cancer patient, they are increase their anxiety, depression, and always worry to become infected. The most sophisticated person is the children. And children who are the graded 2 to 6, they are suffering with anxiety symptoms and depressive symptoms. By roughly 20%, almost 2/3 are worried always about becoming infected. Also increase regression and delinquent behavior. I can share also some important presentation like that in the COVID-19. Another study from Lancet, UK based, on April 14, that studied more than 2,000 school had closed, school kids, and then school had closed due to the pandemic. They noticed that anxiety has increased within 83% of the students. Another report by NBC in here, TB network in the USA, domestic violence has increased 20 to 35%. In the USA, National Association of School Psychologists had said that throughout this pandemic, the trouble of sleep, lack of focus and concentration has increased 14%. As I mentioned before, there is a suicidal ideation and suicidal behavior also increased. One of the example, like April 12, US Post headline in news, 15 years old is Jo Biani Smith had hanged herself in California. Also, she had no previous mental illness. And another top ear doctor in Manhattan, her name is Dr. Lorena Embren, had committed suicide on April 27 because she has shaken by coronavirus onslaught. This is the picture. You already know about this. Now, as a psychiatrist, what can we do for the kids and then adolescent group? We can acceptance and validate the situation, because there is no marks of mental health. There is no marks. We have to we have to understand. Acceptance and validation means then fact checking and create a safe environment for them, appreciation and positive thinking, practice kindness, empower them by modeling positive behavior, limit screen time, and prevent cyberbullying. Common behavioral exercise we all practice: decrease news feeds, daily routine work, spend quality time, engaging in creating activity, virtual connecting with the family members and associate people who are known to you, spiritual practice, definitely, and sleep hygiene. You have to maintain a healthy diet, practice. Another coping skill you can practice, self-soothing behavior, just hugging and then hugging your kids, and then deep breathing exercise. You can read the book, music, and muscle relaxation techniques. You can practice yoga and decrease negative, that's most important things, negative ruminating thoughts. For adults and general people, contact with the primary care physician as you need, and then contact with the psychiatrist for a specific medication adjustment, especially the medication for antipsychotic medication with any hydroxychloroquine or any other things could be a fatal, azithromycin could be a fatal cause of the COVID-19 patient. In this pandemic, we have to check it because QT prolongation. And then psychiatrists can help with telepsychiatry. So our specialist and all the investigator, and then they say to that next world could be a mental health pandemic. So we should take care and be aware of our mental health. Thank you for listening, and thank you for your time. And a special thank all the members and organizers in Bangladesh Medical Association in North America. Thanks.
Thanks. Good data. Thanks.
Thank you, Dr. Mohammed Islam Pshychiatric. Thank you for your nice presentation. Now our next presenter, and he is the last presenter, Dr. Anando Malo. He is a residency applicant. At present, he is working as an infection control practitioner at Interfaith Medical Center, Brooklyn, New York. He is going to present us two parts. First part will be about the research work, and the second part will be the PPE, personal protective equipment. Welcome, Dr. Anando Malo.
Thank you, Dr. Barnali Hasan, and thank you, BMA Medical Association of North America, New York chapter, for giving me the opportunity to speak in front of you. It is a privilege for me to speak in front of you. Good evening, everybody. I'm going to speak about the research work on coronavirus. Most of the research work related to treatment is already discussed by our presenter who speak about the treatment of coronavirus. Now, a lot of research work going all over the world. There is no specific antiviral drug has been proven effective as treatment for the coronavirus, COVID-19. A lot of research study ongoing around the world. There is specific treatment, no specific treatment established with proven benefit. I'll mention only few of that. First, remdesivir for treatment of COVID-19. A multinational randomized double-blind placebo-controlled trial. Remdesivir was given for up to 10 days or until death or discharge, including 1,059 patients with confirmed COVID-19 and evidence of lung involvement. 89% had severe disease, and 26% were receiving invasive mechanical ventilation or extracorporeal membrane oxygenation as baseline treatment. According to a preliminary report, remdesivir resulted in a faster time to recovery, which is defined as discharge from the hospital or continued hospitalization without need for supplemental oxygen or ongoing medical care. Remdesivir reduced hospital stay for 4 days, while median 11 days versus 15 days with placebo. Remdesivir was not associated with statistical significance for clinical benefit or any mortality benefit. Here the image showing this slide in the left side showing cumulative improvement of the treatment along versus the days of the treatment. Remdesivir showing the red color and control with blue. There is no significant difference, but little bit better with the remdesivir. In the right side, also showing the viral load along with the days of the treatment. It does not make any significant difference for the treatment versus placebo. Now, hydroxychloroquine and chloroquine. There is significant data, insufficient data, whether hydroxychloroquine or chloroquine has a role in treatment of COVID-19. The US FDA revoked its emergency use of authorization for their agent in patients with severe COVID-19 treatment. A preliminary unpublished report from a large randomized trial on hydroxychloroquine did not appear to have benefit for hospitalized patients. That trial reportedly found no difference in 28 days mortality among 1,542 patients who were randomly assigned to receive hydroxychloroquine compared with 3,132 patients who received standard care, like other medical treatment. There are also no difference in length of hospital stay or mortality benefit. The graph showing no significant difference with treatment of hydroxychloroquine or treatment without hydroxychloroquine. This slide showing risk and risk of death increase or decrease with hydroxychloroquine and ventricular arrhythmia. which increase or decrease the rate of death with severe COVID patient. Here, this study shows more of the death reported. Also, death due to arrhythmia reported more cases. But hydroxychloroquine is safe for the people to take for malaria, rheumatoid arthritis, lupus, for whom they are shown to have benefit, experts stress. Now, dexamethasone for the treatment of the COVID-19. A steroid, dexamethasone, is the first drug shown to help severely ill coronavirus patients, according to the scientists in Britain. The trial was randomized, controlled clinical trial, the gold standard for the medical research. About 2,100 severely ill COVID-19 patients were given low doses of dexamethasone, orally or intravenously, once a day. Their outcome were compared with 4,300 patients who had received usual care. The trial was stopped early because the investigator felt that the benefit was obvious. This diagrammatical study established the red line, dexamethasone had better outcome than placebo. Now, ivermectin treatment for the COVID-19. Although several clinical trials are now underway to test the possible therapies, the worldwide response to the COVID-19 outbreak. Here, highlights about the ivermectin. It is an inhibitor for the of the COVID-19 causative virus in vitro, outside of the human body. A single treatment to effect 5,000-fold reduction of virus at 48 hours in cell culture. Ivermectin is FDA approved for parasitic infection and therefore warrant further investigation for possible benefit in humans for COVID-19 treatment. Ivermectin is widely available in the world, so its inclusion on the WHO model list of the essential medicine. A preliminary findings released by US-based clinical trial and of antiparasitic drug, this ivermectin, found that the mortality rate for the coronavirus patient shown to reduce up to 40%, according to the medrxiv.org site. The ivermectin study began in the March as part of the large Australian lit clinical study focused on 280 patients, 173 of whom were treated with the drug at 4 different hospitals in Florida. The effect of ivermectin on reduction of viral shedding among the mild to moderate patient and shortening of the symptom resolution time. World Health Organization reported the available pharmacokinetics data from clinically relevant and excessive dosing studies indicate that COVID-19 inhibitory concentration are not likely to be attainable in humans. Here, the concentration of the medicine and the time of the treatment of ivermectin pharmacodynamics showing IV50 achieved the target. IC50 that mentioned that higher the inhibitor to be considered as a good outcome. So still it is inconclusive. We need further study. Thank you very much, New York chapter, Bangladesh Medical Association of North America, for arranging this wonderful presentation webinar. Now I'm going to start my second part of the presentation. Welcome back. As you know, I work as an infection control practitioner. I have been dealing with personal protective equipment at my workplace. I'm going to speak about that now. PPE is used every day by healthcare personnel to protect themselves, patient, and the others, like family, when providing care. Before we speak about the PPE, I would like to mention some data presented by CDC and National Health Safety Network, hospital-associated infection data, which will explain the significance of use of PPE. In the United States of American hospitals alone, the CDC estimates that healthcare-associated infection account for, in general, an estimated 1.7 million infections in USA and 99,000 associated deaths each year in the United States. The financial benefit of using this prevention practice is essential, very essential. It estimated about 20 billion reduction, 25 billion to 31.5 billion in medical cost saving each year. Many hospital-associated infections can be prevented through the strict adherence to PPE, evidence-based best practices, which can lead up to 70% reduction of hospital-associated infection. There is the 4 important reasons to use PPE at your workplace. It keeps you from being liable for your own injuries. Long-term conditions may result from a failure to protect yourself. You only have one pair of eyes. Every year, roughly 2.4 million eyes injuries occur in the United States, both at work and during leisure activities. 90% of eye injuries could have been prevented by safety eyewear. It increases the quality of your workday. Here, showing some personal protective equipment to prevent general infection. All of this is well known to all physicians. Who needs PPE? Patients with confirmed or possible COVID infection should wear a face mask when being evaluated medically. Healthcare personnel like doctor, nurses, respiratory therapists, housekeeping, all who directly involved with patient care. Here showing consequences of donning on PPE. It started with hand hygiene, gown, mask, then eye protection, finally the gloves. How to put on PPE? First, identify and gather the proper PPE to don. Perform hand hygiene using hand sanitizer for 20 seconds. In United Hospital, every patient room inside and outside having a automatic hand sanitizer. Put on isolation gown is the next. Then put on N95 respirator or higher mask. Then the face shield or goggles. Finally, put on hand gloves. Healthcare personnel are now enter patient room. This PPE arrangement in a hospital is usually in front of the patient door. outside. Here, the person is ready with proper PPE to take care of the patient. Mask do and don't do. Here, proper way of placing the mask in face. Next, showing the left image, long ways. Finally, how to remove. For the respirator on the right side, first the proper way to put on, then wrong, then finally how to remove it. How to take up PPE, donning of PPE. First, remove the gloves as it is considered contaminated after examining a patient. Then remove the gowns. These two will be inside the patient room. After that, healthcare personnel may now exit patient room. Outside, from the outside hand sanitizer, sanitize hand for 20 seconds. Then remove face shield or goggles. Then remove and discard respirator. Again, perform hand sanitizer after removing the respirator or face mask. Or anytime need to putting it back again. Here, showing consequences of doffing of the PPE step. First gloves, gown, eye protector, then respirator. Finally, wash your hand. Other way showing the remove of the gloves, gown, and throwing the PPE. Finally, we shall overcome. New York has climbed the mountain, and together we have made it the other side of the hill. Thank you all for your interest and attention. At the last moment, I would like to thank again Young Physician Secretary to be our mentor and Dr. Mujibur Rahman for a special care of each of the young physicians for this presentation. Thank you all for listening and participation.
Thank you. Thank you, Dr. Anando Malo, for your nice presentation. Up to now, if I'm not wrong, 47 doctors in Bangladesh have sacrificed their life. And in United States, in New York, and all over the America, in Bangladeshi doctors were 4, if I'm not wrong. So it's very important how we are donning and doffing program. We are looking at your program today and continue and carry it. We would like to listen from our beloved and our respectful, our mentor, Dr. Mujibur Rahman Mujumdar, Brookdale University, pulmonologist, critical care, and geriatrician, internal medicine, all 5 board certified. Our beloved Dr. Mujibur Rahman Mujumdar. We'd like to listen from you.
For arranging such a wonderful, a complete presentation, very organized way, A to Z presentation on COVID-19. My biggest thank and biggest applaud for all the young physicians. They worked very hard and they came up with a very nice, wonderful presentation, very focused to their topic. I really admire them for their wonderful work. And I like to also thank especially for the person from UK. At 4 in the morning, he's up to listen to this presentation and also present. He really tells a lot about the commitment of all those young physicians. I'm pretty sure looking at their presentation and their commitment to medicine and to COVID-19, they'll be very, very successful physician. In fact, they'll be much more successful than all of us. We are in the old generation. And I wish all of them a great success in their career and their life. Thank you so much. Thank you, Barnali. Thank you, Yusufbhai. Thank you, all the EC member of New York chapter. And
Would you unmute yourself?
Dr. Mustafa Hassan. Also, I'm getting in the text a lot of encouraging words, and we are really thankful. And we tried our best, and we will do our best, and this is our promise. Now, I would like to convey our message that we want to do the best. We want to be the honest doctor in America. So I always tell them, let's prove America that we are from Bangladesh, we are the honest doctors, and we did our best, and we are the best. Thank you. I would like to transfer my moderator now, our scientific secretary, Dr. Kaji Rahman Shajul.
Thanks, Dr. Barnali Hassan. The best thing that I think you are the most hardworking doctor so far I saw, though my knowledge does not go beyond that. So next, there is our engineer. We used to fight with engineers, but engineer is so friend also here. Let our engineer to say few words who helped all other doctors here to formulate their presentation. Barnali? What's the name of that engineer? I forgot.
Dr. Sheikh Jilur Rahman, he's the motivational speaker, and he's the engineer. He lives in Maryland, and he wanted to give us little encouragement words. Okay, we go to the, yes, I cannot hear you.
Yes, sorry about that little difficulty. Assalamu alaikum, namaste, and everybody good Coast, and of course very late in the UK, as Dr. Mujibur has mentioned. But I did not want to take any credit or anything like that. But I just wanted to mention a couple of comments. That's all. I see all the renowned doctors of the United States and Bangladesh who are already here. So this is definitely I don't take anybody's time lightly. At the same time, I just want to mention from my perspective, my point of view, and the expertise that I have on the presentations and putting an event like this together. Even though this is a new norm, that this is a Zoom and online event that we are going into as a normalcy of going forward way of doing things, but still it takes time and effort, and I have seen each and everybody doing the things, and the presentation and everything, this is unparalleled to everything. The reason behind that is unbelievable information. There is no way I can retain all this information that I learned in one night. That's true, but at the same time, I did learn a lot of things. But my only 2 cents and a very short summary of it is everybody presented with their heart. That's what this is all matter. And they care about the people, about the audience who are listening to them. And you can feel that, and you can understand that is the case. And that's what makes a difference. Everybody is a doctor. Everybody can be a doctor. Everybody can treat a patient. But the way some of these people are caring and touching, that's what makes a difference. And that's what these people are. So this integrity, this honesty is awesome. And the way it was presented, the format and the actual visual presentation, this was definitely great. So I work as a mentor for people. I work as a coach, and I'm still working with different people, with different organizations for that. But this is definitely something to be respect. So that's all I wanted to say. And thanks to Dr. Barnali Hassan, as well as all of you who actually participated. The participants are the ones who made it great. So thank you all, and appreciate taking the time at this hour and in the evening and wherever you are for your time. So back to you, Barnali and Dr.
Thank you. Thank you, Jilur Rahman.
Okay, thanks everybody. Now we'll go to question and answer. If any question and answer, though it is late hours of night, but we are here. If any question and answer, then we'll our president-elect Dr. Muhammad Abi Siddiq will we'll close the meeting. Before that, let's any question answer open forum.
I have a question to Dr. Majumdar.
Majumdar, yeah, Mujib Bhai, are you here?
Yes.
Okay.
Okay, so my question is, even though we have seen initially we treated COVID with the steroid, but later on it showed the study that it doesn't help. Is there, but practically when I was treating the patient with my attending, we tried the steroid and we saw tremendous improvement of the patient. So do you think it could be the bias of the study or the clinical benefit and the study, there was a disparity? What is your opinion as a pulmonologist and the COVID?
Well, my opinion is simple. In many disease, especially in a severe kind of disease in ICU, many times as a last resort, we jump on steroid. And this is what happened in the beginning of the COVID infection. We didn't have much knowledge at that time. Different people use different things for the patient because intention is to save them. And at the beginning, some people use solomedrol and prednisone and things like that, but it was not an organized that those patients being helped by the steroid or not. But another thing also happened at the beginning of the treatment. Our ventilation parameters that we followed as if that it is ARDS, and we use ARDS protocol, ARSNet protocol that we use, that might have also affected, in a worse way to the patient. So even if patient is on steroid, but our ventilation management system was not appropriate for this disease, we might have a wrong outcome. So we cannot tell at the beginning what we are doing. We are doing everything. We are throwing we call it here, we throw the kitchen sink to this, this disease at the beginning. But lately, as you have seen from England, that the dexamethasone, which is one kind of steroid, is being used and used in severe, moderate to severe patient, and that showed some benefit, especially mortality benefit. Mild patient did not do well or did not show any significant benefit. I myself, as some of you know, that had a significant disease. I was affected by the COVID-19, and I had bilateral pulmonary infiltrate, bilateral pulmonary embolism, and all those things. And I also took a steroid, prednisone, and that I believe it helped me also. So yes, there is a value to steroid, but may not be in the mild disease. I believe moderate disease and severe disease, if we start using that, early in the process, it may give you better result. But if we wait too long, and by the time the lung is damaged because of the poor ventilation system, and also septic shock kind of picture, renal failure, and all this other multi-organ failure, it might be too late at that time, and to use dexamethasone or any other steroid and expect a good result. So at this point, I believe that moderate to severe patient, that's at least the data that came out recently showing, and we need more.
Shika.
Do you hear?